We're delighted you're here. We hope that you'll get a lot out of this initiative. And I'm Dr. Robert Uzo. I know many of you. I'm the president and CEO of. Just do this. Can you reboot this thing? I'm president and CEO of Fox Chase Cancer Center. I'm a urological oncologist. I know many of you in my professional roles in many capacities, and I want to thank you again very much for coming. It's been said that progress in cancer occurs very, very slowly and then all at once. And we're in one of those times where progress in cancer is occurring all at once. It is a remarkable thing to think about how things have changed in the last 10 years. A lot of it is from the scientists, a lot of it is from our partners in industry, and a lot of it is because all of you have trusted us with your care. Whether it's routine care, whether it's clinical trials, you've helped us to advance the field. You've allowed us to have your data, to put it into our databases, to anonymously publish, to share with our colleagues. Each year, the urology group here and the GU group here publishes nearly 100 articles, abstracts, or chapters that we go then present at our national meetings. And that's thanks to all of you for helping us to go out there and help make this world a better place. So I'd like to thank you. I would also like to take just a short moment to honor the people who can't be here, who have lost their battle to cancer, whether it's prostate, kidney, bladder, or any tumor. We all have family, friends, colleagues who have lost that battle. So if you don't mind, just join me for a moment of silence for the people who couldn't be here. Thank you. One of the best parts about this job is that we work so closely with great and smart people, and that you allow us to be an important part of your lives. You didn't choose to have this happen to you, but you trusted that we would help walk you through that journey. And we feel that to be a great, great privilege and a great, great honor. And when we come into work every morning and we think about the opportunity to impact each of your lives, we consider that a privilege and we consider that a duty. And so last week, we launched this big initiative at the American Urological Association called the Urological Institute. The Urological Institute is one of the largest, certainly in the state of Pennsylvania, one of the largest in the country, where we've incorporated experts in radiation oncology, medical oncology, urology, and now a whole group of people and experts in benign urology. I say benign urology because most people that have urological cancers also have diseases that are benign in nature but affect the urinary tract, whether it's the need for complications after cancer surgery or whether it's just part of growing old. And so the Urological Institute is now one of the largest in the country that is looking to grow and continue to bring our brand of care out to more and more people. And I'm very proud that many of the leaders are here today. One of them is Dr. Alex Kudikoff, who most of you know is the department chair of urology. And one of the vice chairs, Dr. Jay Simhan, who is an expert in reconstructive urology. So I'm going to turn the podium over to Dr. Kudikoff, who's going to get us started. Thank you.
Thank you, Dr. Rizzo. Let's see if I can get the microphone working better than him. So thank you all for being here. I see a lot of familiar faces. Thank you so much for the support and for coming. To speak a little bit more to the Urologic Institute, this is really a tremendous effort that is, hasn't been tried very much around the country. And this is an idea of when folks come for urologic cancers, like Dr. Rizzo said, there's a lot of non-cancerous issues, especially survivorship care that needs to happen, and to have it be in one team and to really be across the region. We're not only going to be at Fox Chase, we're going to be at Temple, Maine, we're going to be at a lot of satellites, and folks can come to see the providers Some of them you know here at Fox Chase, some of them the new teams that have joined us, and some of them folks who have been here for years across the region and who have very, very deep expertise in certain parts of urologic care. And you can't do it all. A lot of us take care of cancers and several cancers, but there's no way to keep up with modern medicine in every single space. And what the Urologic Institute is going to do for this region is to really be the premier experts in urologic care when it relates to whether cancerous problems and non-cancerous problems. And just to tell you a little bit about the folks who comprise the institute, I came to Fox Chase in 2008, so 15 years, and I really grew up here. This is a place that trained me. This is a place that gave me my first job. This is a place that allowed me to grow my career both here in the region and both nationally and internationally. And really, just about every member of this team has this background. Dr. Simhan was a resident here, and now he's back at the institute. And there's such deep roots, and this team has such a deep connection. And as you can see at Fox Chase, not only just the physicians, but the nurses, the support staff. A lot of people live around this area. This is a very, very unique place that I think is not replicated in such a way, really just about anywhere in the country. This is you see the magnet signs. What that means, it's gotten the award for the best nursing in the country 6 times in a row. This is the most in Philadelphia. And the nursing care that you get here is really unparalleled. There's just such dedication and such investment for every single patient at the place that I have a lot of physician friends. I know folks at every institution in the city, and Fox Chase is very, very special in that way. And all of us who've been here through all of our careers, I get a job offer every month, and I delete that email. There's no other place that would work other than Fox Chase. But without further ado, we have a program. So first, I'd like to thank our exhibitors, and let me just kind of go through the list and make sure they get recognized. Our video exhibitor is Exelixis. Our gold exhibitors are AstraZeneca, Caris, ASI, Exact Sciences, Foundation Medicine, Natera, Pfizer, and Tempus. Our silver exhibitors are AngioDynamics, Avi Oncology, Bristol Myers Squibb, EMD Serono, Endeavor Biomedicines, Gilead, Janssen, Merck, Novartis, Photocure, Sanofi, and Telix Pharmaceuticals. So really the kind of who's who is oncology. We really appreciate your support, and thank you for supporting our patients. And the advocacy groups are here, really important force out there, and a growing force. There is Bladder Cancer Advocacy Network, Kidney Cancer Associations. If you as patients haven't connected them, that is really just a tremendous, they do a tremendous job out there, especially for the newly diagnosed patients, for patients who need support, different stages of their cancer journey. And I, invite you to connect with them to support your journey, but also to connect with them to support other patients. They really do very important work out there. So I'd like to acknowledge the docs who took time out of their busy nights to be here. I see them around the room. Dr. Chen, Dr. Miran, Dr. Zibelman, Dr. Karen Wong somewhere. There she is. Dr. Simhan, and I believe Dr. Cohn is on his way. He got stuck in the operating room. He's coming. He promised not to rush the surgery, so don't worry. Okay, so I think we're going to break into 2 sessions. For those of you attending the bladder and kidney breakout, you will stay here, and that will be with myself, Dr. Cohn, and Dr. Zibelman. And the prostate cancer breakout will be in the auditorium just over there, right there. Well, Sarah to the auditorium. And that's with Dr. Chen, Dr. Miran, Dr. Simhan, and Dr. Wong. Okay? All right.
I'm Matt Zibelman. I'm one of the medical oncologists here. And Dr. Kudikoff and I and Dr. Cohn, when he arrives, are going to just take a few minutes to talk about some different topics relevant to kidney and bladder cancer. And then sort of open it up for questions, and we're happy to sort of at that point answer questions that people have about a variety and range of topics, and I think some of our people around the room will sort of help with that. So as a medical oncologist, my role is to give medicines for patients either who have kidney or bladder cancer that has spread from where it started, or in some cases to help prevent the cancer from coming back. And so one of the therapies that we use that's common to both kidney and bladder cancers are immunotherapy. And I know there are patients here who have been beneficiaries of that. And immunotherapy, sorry for the sound. Too close again? I can just talk loud, but so immunotherapy is sort of a newer and become a really important pillar of how we treat patients across a variety of cancers. And it's really the idea that cancers are one of the reasons that they develop the ability to grow and spread is that they find ways to hide from the normal processes of the immune system. And our immune system is designed to help protect us from infections and from cancers and things that aren't supposed to be growing and spreading the way they are. And in order to be able to grow and metastasize, cancers finds ways to avoid the immune system or hide from that. And they give off signals that are really there for good reasons. They're there to prevent the immune system from overreacting and to an infection or to attacking our normal tissues. But the cancers take advantage of that and use it to be able to grow. And so these immunotherapy drugs work by blocking those signals. And so the immune system can then go on and hopefully recognize the cancer again and mount the immune response that it's intended to do. And the exciting thing about these immunotherapy drugs is that our immune system has sort of inherent memory, and when the immune system is recognizing a cancer as foreign, it can mount an immune response, and that response can be durable, and for some patients can last months to years to many years, and there are patients here who have been lucky enough to be in that situation. We're still learning a lot about these drugs and about the cancers that they work for. We're still trying to figure out better markers, ways to predict ahead of time which cancers are more likely to benefit from these drugs and which ones aren't, and that maybe we can use other therapies for. And so to this point, we use these drugs somewhat indiscriminately without clear markers to help decide to use them. We also sometimes use them in combination with other therapies. For kidney cancer, we sometimes use them in combination with oral therapies, and they pair nicely to help control patients' cancers. And in bladder cancer, we're starting to use them with another new drug that is somewhat is a new member to the sort of group of drugs we use for bladder cancer. And then we're also starting to use these drugs for people who have had cancers localized and surgically removed as a way to prevent these cancers from recurring. And so both for kidney and bladder cancer, there's some patients with high-risk cancers that were removed where using immunotherapy may prevent that cancer from returning. And so these are drugs that we're using commonly as part of standard practice and also using as part of clinical trials and trying to find ways to use them either with different partners, different drugs that may help them work better, as well as finding ways to help improve the side effects that can be associated with some of these immunotherapy drugs. And everything has risks of side effects, and these drugs are not immune to that. For many patients, they can do very well with very few side effects, but there are immune side effects that can be serious, and we spend a lot of time, and it's a big interest of mine of trying to understand these immune side effects better. So I'll sort of leave it at that for now. I'm happy to, at the end, answer questions people have, whether it's about immunotherapy, but about other medical oncology topics, as they come up. Dr. Kudikoff?
Yeah. So I think Matt is, when Matt and I went into practice, immunotherapy was just in trials, and we all of a sudden started seeing our patients who really didn't have much hope of sort of making it, even a few years, kind of keep coming into our offices and keep rocking grandkids on their laps, and it's amazing what sort of kind of the revolution in cancer care that we witnessed, and sort of, at least for me, it was and I think for most of us, it was really unexpected. These were new drugs. They sort of they worked in trials, and then some of them for some patients just became such incredible home runs. And from a surgical side, you sort of did these complex surgery for advanced disease, and you really thought that you gave people maybe a few years, and then I just saw somebody today 13 years later. It's amazing. There's but let me talk a little bit about the surgical side. And so we're talking, topics are bladder cancer and kidney cancer, and they're sort of very very different topics. But actually, for bladder cancer, where the condition is urothelial carcinoma. It's the tumor from the inner lining of the bladder. And that inner lining also is present in the ureters, which are the tubes that run from the kidney down to the bladder and inside of the kidneys. So some of our bladder cancer patients end up developing tumors in their kidneys. So the bladder and kidney in that urothelial disease are actually very intimately linked. And as some of you know around this room, we really watch the ureters and the kidneys in folks who have had bladder cancer. And, whereas kidney cancer, when we think about kidney cancer, it's tumors that not arise from the inner lining of the kidney, actually arise from the meat of the kidney. And that's what we traditionally mean by kidney cancer. But you can develop urothelial carcinoma, which is the inner lining in the kidney, which gets a little bit confusing. And I almost think that kidney cancer that's from the inner lining, urothelial, is also almost like an orphan disease, because it's sort of not quite bladder cancer, not quite kidney cancer, and there's, it gets a little bit complicated. And I think that patient population, at least in the advocacy world, and I know BCAN really advocates for them, but still, they're under the name of bladder cancer. I think that's an opportunity to sort of support those patients, because I think that those folks get a little bit lost because they just don't know which group they really belong to. As far as surgery, so especially for bladder, I'll tell you, there were, just like for medical oncology and bladder cancer, it was a wasteland. For 30, 40 years, nothing new happened. There were techniques that were developed and sort of optimized, but really the mantra was, just like most of surgery, is, when in doubt, cut it out, right? And it was, just taking things out and doing very aggressive surgery. And both for kidney and for bladder, there's been this big push for de-escalation, or kind of ratcheting down how aggressive we are. And, Matt and I have worked very closely together for a number of years, trying to really identify patients in bladder cancer who can basically forego removal of their bladders. And, we've had several kind of seminal trials here at Fox Chase, where some of you in this room have, really been on the forefront of enrolling into, and not, finding a safe way to forego bladder removal. We're not quite there yet. We're still, this is still something that really needs to be figured out, but there is definitely an opportunity. Just to kind of put some numbers on it, when somebody comes, these bladder tumors, the way they develop on the inner lining of the bladder. And they come in several varieties. They come in a high grade or low grade, but one of the gateways to spreading is invasion into the muscle of the bladder. So folks who have muscle invasive bladder cancer, kind of looking down, this barrel of very aggressive therapy, which is classically chemotherapy and then removal of the bladder. We have all these newer techniques, although they've now been, I've taken care of patients now who had their bladders removed 30 years ago, not by me, but, by kind of the pioneers in the field, and they, new bladders were reconstructed from small intestine, and this was sort of pioneered about 40 years ago, 30 years ago. I'll give you a little anecdote about these things called a neobladder that have it's basically sort of, you create a spherical reservoir, kind of, a new bladder from small intestine, and it's got this little chimney on it, where you plug in the tubes they call the ureters, and it's called the classic one that most of us do, although not everybody, there's different varieties, but one of the classic ones is called the Studer neobladder. And so a few years ago, I was at a meeting, and I was having cocktails. I was on an editorial board of a journal, of the European Journal, and somebody shakes my hand. I'm Dr. Studer. He's from Switzerland, and he introduces himself. And I said, Dr. Studer, I actually did your pouch just right before I flew out. He says, oh, you know why we have that chimney? And I said, oh, why do you have the chimney? He says, oh, I didn't think it was going to work at all. I thought it wasn't going to work, and we're going to have to convert it to a conduit, to the regular. He basically built this thing so he had kind of an extension that was kind of the regular urinary diversion, which is an ileal conduit. He had it built in right into his reservoir just because he really didn't think it was going to work. Well, it worked, and hundreds of thousands, probably millions of patients have gotten this diversion, and so. Although that was developed, decades ago, still there's nothing better than your own bladder. And when people get chemotherapy, about 30% of folks who we operate on after chemotherapy actually don't have any residual cancer in their bladders. And now it's not that simple. It's not like that bladder will never develop cancer again, and it's not that that it's completely risk-free to keep that bladder, but it doesn't take an expert to see that that's a huge opportunity to really try to leave those bladders in place and figure out in whom it is safe to just follow those bladders. So we're doing a lot of that here. And Dr. Zibelman and I just saw a patient today who did he enroll?
He did.
He enrolled, yeah. So into this bladder, it's called Retain. So maybe you can talk about Retain.
Yeah. So I'll sort of take that, one of my other roles here is as the director of research for the GU group. And so I'm involved in a lot of the trials we do. And so I think one of the, exciting things that we do here and as part of my job, and I think that's really important for what we offer for patients, is the opportunity to be involved in clinical trials. And some of these are trials that are homegrown, that we've conceptualized and developed here. And some of them are trials with partners from some of the industry partners that were here today and other places. And these are great opportunities for patients to get access to new therapies or new ways of treating cancer. And some of them are ideas like these Retain trials. And so these are trials that our investigators wrote and designed. And really, they, piggybacking on what Alex said, it's the idea that can we predict who these people are who get chemotherapy and got their bladders out and have no disease left. If we could predict who they are, could we safely choose those patients and allow them to retain their bladder, which is where this name came from. And from earlier work that we did, spearheaded by Dr. Plimak, who is sort of our deputy cancer center director and our longest tenured medical oncologist here, she determined that when we give chemotherapy, it turns out there are some mutations that patients have in their tumors that seem to make the cancer particularly sensitive to the chemotherapy. And those patients seem to have a higher percentage of having this complete response to chemotherapy. And when we go in and take their bladder out, all their cancer is gone. And in the long run, we know that those patients have the highest likelihood of not having their cancer return. And so the idea of this trial is if we can take the tissue just from your original biopsy, determine if you have one of these mutations that we've identified increases the chance that chemotherapy is going to help, and then put you through the normal chemotherapy we do, those patients then have the option of not proceeding directly to surgery and retaining their bladder. And we continue surveillance, and if there's a recurrence, we manage it the way we would otherwise. But we've been really lucky to have some patients benefit from that, some patients who are here today, and be able to go on and retain their bladder. We now have moved on to the sequel to that, so Retain 2, which is the trial that the patient, Dr. Kudakava, and I saw today, we were able to put on. And this adds an immunotherapy component. So as I talked about immunotherapy and its role in both kidney and bladder cancer, we now are combining chemotherapy and immunotherapy for these patients to try to increase the percent of patients who have that benefit. And so, this is an ongoing trial, and we'll learn over time if there's a benefit of that. But I think this is, the kind of thing that we're continually trying to do here is how can we better use the therapies that we have, either in combinations with other things, to help improve the, outcomes for our patients. And so, I'll put my biggest plug in for clinical trials. We really want to give patients the opportunity to go on these trials, and not just to benefit the larger community and learn more about that, although that's certainly important, but hopefully to also help individual patients, with the cancers and through their journey.
I thought it's for the folks who are here we've been talking about bladder a lot, but for the folks who are here to hear about kidney cancer, I know, looking around the room, I know that several of you here enrolled into kidney cancer clinical trials, which really, if you say Fox Chase out there, kidney cancer is really the flagship disease site. I mean, this is some of the seminal work in kidney cancer was done here, both on the surgical side and the medical oncology side. Some of the first New England Journal papers in what's called targeted therapy, where this idea in kidney cancer where you can disrupt the communication between the tumor and the blood vessels. And so these kidney cancers, they're really oxygen hungry. They really need a lot of oxygen, a lot of blood vessels to grow. And, this started with this man who should have absolutely gotten the Nobel Prize, but unfortunately you can't get a Nobel Prize after death. So this Judah Folkman he was at Children's Hospital in Boston. He was a surgeon, and he was sort of the quintessential surgeon scientist. He was making his observations during surgery and seeing that, for instance, when you take out a main tumor from a patient in some of these cancers, that some of the satellite tumors all of a sudden start withering. And what he identified is that there are factors that these tumors secrete that promote blood vessel growth into those tumors, but not only into the primary tumor, but also into the metastatic sites, into the other sites. And he basically spent a career looking for these factors that are responsible for that, and looking for agents that can block it, right? And so on the heels of all that work, these agents came out called targeted therapy agents, and this was in the late 2000s. Mid to late 2000s, these drugs came out, and now you hear them called TKIs, but they were mTOR inhibitors at the time. And Fox Chase was in the absolute forefront of that. And one of the first New England Journal papers with Gary Hooties, who was the chief of GU Medical Oncology, was from here. But both on the medical oncology side, but also on the surgical site, this place really prides itself in kidney cancer care. A lot of kidney cancer care now is, again, also this de-escalation theme of, when do we actually have to do surgery? And, for one of the largest active surveillance, what we call a cohort, a group of patients that have received active surveillance in the world was here at Fox Chase. Rob Russo, who you saw here, was a pioneer in that. Really, the idea of these small renal masses that, if somebody comes in and they're elderly and they're frail, do you really need to operate on them? Are you really going to change their destiny? Or are you just exposing them to immediate risks of surgery without any potential gain? And, he and the group, with him later showed that it was very safe. And, some of what's in the current guidelines, the world, both European and American guidelines, is based on what, work that was really pioneered here at Fox Chase. We just published just a few years ago one of the largest series with the longest follow-up of active surveillance. So that's an important strategy for us here, where not every patient, we try not to be the surgeons that are barbers, where you come in and you get a haircut. There's a lot of folks that we kind of explain that you really, this is one of these things that you can really watch both in kidney and in prostate cancer. But when surgery is needed, we really pride ourselves on offering the latest surgical techniques. And in kidney, the priorities I always tell patients are sort of, number one is to cut out the tumor and cut it out cleanly. Number two is to try to preserve the kidney if we can. And then, we really participate actively in this debate in the in the kidney cancer world is, when is it appropriate to save the kidney, and where is it appropriate to do partial, and really an unanswered question. There's a lot of opinions around it, and we really contribute actively to that field. And third is how to do minimally invasive techniques. I mean, one of the first series of robotic partial nephrectomy was here at Fox Chase. The first 100 cases were done here. This was one of the first robots in the city. So, building might be old, but some of the stuff that gets done here is really cutting edge. We work very closely with Matt and his team, and maybe talk a little bit about the adjuvant work.
Sure. So I'd be happy to. So adjuvant therapy is the idea of giving treatment after patients have had their cancer surgically removed to try to prevent or lower the risk of recurrence. And we think that cancers recur because microscopic disease is able to escape from the organ where it started, likely before surgery ever happened, and eventually those micrometastases are sort of destined to grow. And so the idea of giving an adjuvant therapy is giving a medicine that goes everywhere after surgery to try to eradicate that residual tissue and prevent it from ever growing. While there are multiple cancers where we do adjuvant therapy, and chemotherapy and other therapies have been important, it's been somewhat elusive for a long time in kidney cancer. The TKI drugs, the blood vessel targeting drugs that Dr. Kudikoff talked about, while they can be very effective at shrinking kidney cancer tumors when the cancers have spread, we studied them extensively, and the Fox Chase team was a big part of some of these really large trials trying to show a role for some of those therapies in the adjuvant setting to prevent recurrence. And unfortunately, they really haven't shown the long-term benefit that we look for in those drugs. And so more recently, we've done a similar evaluation with immunotherapy in that space and trying to see if immunotherapy drugs may have a better role. And what we've seen is one of those drugs, a drug called pembrolizumab, has demonstrated a benefit in that setting. So there are patients now that we do treat in the adjuvant setting to try to prevent recurrence of their kidney cancer. And it's another space where we have a clinical trial and adding a newer drug that targets a different pathway in kidney cancer, for which someone did win the Nobel Prize for studying that pathway. And we expect this drug to be approved for all kidney cancer patients at some point soon, but we're part of an early trial looking at this drug in the adjuvant setting and combining it with immunotherapy to see if that combination might increase that percent of patients who benefit. And so, adjuvant space is something that is always challenging and requires, I think, a lot of teamwork with the urology team and our team, and really trying to decide who are the right patients to put on these therapies and who are the patients most likely to benefit. I think one of the real advantages and strengths of Fox Chase is the how we work together and sort of the team structure that we have between the urology group, the medical oncology group, the radiation oncology group, and I'll connect this to clinical trials again, but a lot of these trials that we have to design in here are really depend on teamwork and cooperation amongst the different groups, and they really wouldn't be able to be successful without us working together. And so I think a lot of what we're able to accomplish here, both for patients and certainly with clinical trials, has to do with the commitment that all of us have to taking care of our patients and supporting these trials.
And I'll just add that what's really fascinating to see is that kidney cancer 15 years ago, 20 years ago, was really sort of one of these marginal diseases that no pharma company, just there was no interest. There was nothing really interesting happening. There was no active agents. Chemotherapy didn't work for it at all. Radiation therapy didn't work for it. And it was one of these things, it lived in the surgical world. You try to do surgery on it when you could, and there was really nothing else. And really, to be fair, as far as medical oncology, medical oncologists come out and sometimes they subspecialize. And, I have to say that, nobody really went into GU medical oncology. Well, now we got the brightest minds like Dr. Zibelman entering it, because really kidney cancer is sort of the path to approval of new agents and new targets. It really just all kidney cancer is kind of at the center of modern oncologic care, amazingly.
Yeah. I totally agree with that. And one of the reasons I loved going into GU oncology was the the mix of cancers that we deal with and the different groups of patients. And I think it's a really exciting field because of the science that's along with it and the different groups of patients. But I think kidney cancer is a great example of that. I started my training just as the TKIs were really becoming the mainstay of therapy, and immunotherapy was just in the very, very early stages, and have gotten to sort of grow up as really the whole landscape has changed, and patients who would only live for maybe a year or two at most when I was just starting out now have median survivals in 5, 6, 7 years, maybe even longer. And so it's really been a huge change in a very short amount of time, and really has altered the field. And Dr. Kudakov is right. We're continually getting new therapies. We have a new drug that that I mentioned that we expect to be approved in the not too distant future, and hopefully others along the way. So it has changed dramatically. Pharma companies are building their portfolios based on kidney cancer, and it's really a dramatic change in really less than 10 years.
So I just got a text from Dr. Cohen that he's on his way. So as he's making his way, and I'll just give a little bit of introduction to him. So Dr. Cohen is maybe the nicest person you'll ever meet, and the most patient. Takes care of my mother-in-law. Which,
That's where the patients proven.
No. So going back to bladder, there's a lot. When we're talking about bladder cancer, kidney cancer, it's sort of top of mind in this room, but that's a really rare condition. Actually, what's really common is benign issues with one's bladder. I mean, that is just as your hair grays, your bladder stops working, and this with the expertise that Dr. Cohen brings are really unmatched. He's a fellowship trained urologist who is an expert in female pelvic floor dysfunction, and some of the skill sets that he brings are just invaluable to patients. And he is the patients that get sent to him in the Philadelphia area are folks that urologists from across the regions just have thrown their hands up and can't help, and Josh has the tools to really help them. So he'll come here. He'll speak to sort of his work, really unbelievable work. And now as part of the institute and part of kind of the way we've structured the care, it's I can refer somebody to Josh and they can see them literally. He's in the next hallway. I mean, sometimes he sees them that week or that day. So it really is sort of really refreshing how this model is able to support our patients. But maybe while we're waiting for him, we can do the Q&A and get some questions answered if folks have some questions. Go ahead.
I think we have somebody bringing a microphone to you. One second.
You hear me?
Yes.
Yep.
So I had bladder cancer. It's going on 9 years now. Dr. Rizzo's been taking care of me for 9 years. I'm at the point now where I get the cystoscopy once a year. Now you mentioned that the epithelial cells in the inner part of the bladder go up through the ureters or the urethra into the kidney. So in 9 years, they haven't been examined. My bladder gets examined all the time, but nothing else has been examined. So should it be, or is that the way?
It depends on, there's sort of risk stratifications for that, and it depends on the nuances of each case. And there are some cases where that, the risks are so low that, regular sort of scans are not indicated. So, I defer to your team, but yeah, I mean, there is a finite risk of that, and it's sometimes you do examine them.
Right, because initially when they studied everything else with the dyes, they said that was all good and clear. So
yeah,
that would indicate then.
Right, and and the other piece here is when surveil your bladder, cells get taken out of the bladder, and those cells, if there was something up top, they would drip down as well. So they're
Okay.
yeah.
Thank you.
Yep. Yes.
I had urethral cancer, And unfortunately for me, it was in the top, the middle, and the lower portion. So my kidney was removed. It was removed by Dr. Lallis, who I'm sure you understand and know, robotically at Jefferson. And then a year later, I developed bladder cancer. I'm now under the care of Dr. Uzo, and I have had 2 sessions of 6 treatments each year. And the second time, fortunately, it went into remission. Now, I'm interested in whether or not, because it was a very active cancer, I'm interested in whether or not some of this immunotherapy would be a preventive thing for me. I do get CAT scans, as a matter of fact. Due to get one very shortly, and then Dr. Uzo is going to go ahead and cystoscope me again. The last time I was cystoscoped, I was clear. I'm just wondering if there's any benefit for me to start having some immunotherapy.
Yeah,
I'll let Matt answer, but I'm just going to say, for the BCG, we've actually been very fortunate here. There's been an international shortage, and our pharmacy team, just have to give them a huge shout out. They've managed it incredibly well, and this is one of the places that kind of held on, and we actually were able to provide BCG for really all the health systems. Were sending us patients for BCG installation, and
May I comment on that?
Yep.
Dr. Lallis himself insisted that I go find BCG.
Yep.
Because Jefferson didn't have it. Penn was cutting it in half and giving it to their patients. And so, fortunately for me, I was directed to Dr. Uzo, and
we were able to show the kind of gatekeepers that this place is really going to manage the BCG appropriately, and it was kind of centered here. Yeah.
So to comment on your question about giving systemic immunotherapy, and so while there is a benefit in some patients who have had localized bladder cancer, it's really probably only for the patients who are at highest risk. So patients who had their bladders removed and have features of that cancer that really demonstrates a very high risk of the cancer recurring, because there are also side effects associated with this. And so when you're really trying to balance that, it's the patients with certain tumors with the highest risk who really, it's worth the potential side effects for that. And so, sounds like your case may not quite at this point be where necessary for that. But tell Dr. Uzo we're happy to talk to you about it at any time if he wants to send you our way.
Tell you is that according to Dr. Uzo in some testing, it has not invaded the muscle. It's all superficial. So I was just wondering if you add anything to that, or you let it be.
Yeah. So there is. I guess I'll just add that there is a role. A small role for using these drugs actually in patients who have what we call non-muscle invasive bladder cancer. So patients who have cancer in the inner lining that hasn't invaded the muscle. Usually these are patients who have had BCG and it's no longer or didn't work for them.
Well,
and for some of those,
right.
And so, but for some of those patients, there is a role to use immunotherapy in those patients. There are newer therapies on the way that we're hopeful might even be better than immunotherapy in that setting, but there are some patients who we use that for.
Thank you.
And we had a question over here. Question or no? No?
One thing Fox Chase does really well is great commercials in the morning. And I've recently seen a commercial about bladder reconstruction and how great it is. Has there been super improvements in bladder reconstruction? And if you've had your bladder removed 5-6 years ago, can they go back in and give you a new bladder?
Great question. I'll take this one. So the techniques for bladder reconstruction have really been around, as I mentioned, for many years. It's a really honed surgical skill. There's really not a lot of folks. There's a handful of us around the city that do it. To go back is a discussion. It can be done with certain diversions. There's sort of a variety of different diversions in how bowel is reconstructed in order to kindest man in the world is here. So it's a conversation. There's an option. It's there's trade-offs. It's not easy. So I want to let Josh speak, but I'll tell you there's been a lot of effort. There's basically a graveyard full of effort as far as trying to make an artificial bladder. You think you have an artificial heart, you can make an artificial bladder without sort of going too deep into the details. The problem with any foreign material you pass urine through, you form stones, and all the connections that you make to tissue fail with anything synthetic. There was a very big effort with tissue engineering, where actually they harvested cells from the urothelium and from the muscle, and they put them on scaffolds and grew them. Clinical trial was done, and it failed. Patients died. It did not work. So that effort is actually on hold. So there was, 10 years ago, I was talking to patients that maybe we'll have an artificial bladder or a bioengineered bladder. We're not close. We're not any closer than we were probably 30, 40 years ago. Yeah. But Josh, maybe we'll give you the mic and tell us about all the magic that you do.
Yeah, sure thing. I actually was just reading today they're doing maybe the first bladder transplant.
Yes.
At USC.
That's true.
It's
very controversial.
I get it.
Because for a cancer standpoint, you're doing a transplant on a cancer patient where you're immunosuppressing them, right? You have to give, and so very controversial. But yes, there's that effort. Thanks for mentioning that.
Yeah, sure. I get asked about that a lot, and I think it's a long way off, unfortunately. Oh, I'm sorry. I said I get asked about that a lot. Can I just grow somebody a new bladder? And unfortunately, I think it's a long way off. For maybe for us in our careers, frankly, we'll see. So
ChatGPT will fix it.
Yeah, I'm sure. ChatGPT for everything. So I'm Josh Cohn. My fellowship training was in. There's all these letters after my name that just stand for female pelvic medicine and reconstructive surgery. But I think the main reason the word female is in there is because we have this sort of bridge relationship with urogynecology, so that we can learn, what a gynecologist does and comes up through pelvic floor reconstruction. But I'm a urologist, and so I take care of men and women, and really, manage conditions of the bladder that are not related to cancer. Unfortunately, when patients receive treatments for really anything, there's sort of two schools of patients you might come across, me in the clinical setting. One would be just because they've entered the realm of urology, and we're actually are looking at that, and they are there because they have a kidney tumor, and it turns out, they're also maybe 70 years old and have started to develop some bothersome lower urinary tract symptoms, which are very common. Overactive bladder affects about 1 out of 6 people in the United States, and as you get older, it affects more and more. So that's probably a disproportionate number as you get older. The second would be patients who sort of have developed lower urinary tract symptoms that are bothersome because of the treatments they receive. That's not typically going to be for kidney cancer, but it certainly could be for bladder cancer. We're doing more and more bladder preservation therapy, and maybe you've talked about that, so I'm sorry if I missed it already. But with more and more bladder preservation therapy, one of the things that we have to do is sort of think about what the bladder that's going to be left afterwards. And so some of the intravesical therapies, they do an incredible job at sort of managing cancer and allowing people to keep their bladder in place. And it's sort of my job to try for any of those patients who might have additional symptoms to help manage that. And sometimes that's with just, frankly, physical therapy. Sometimes that's with medications and medical therapy. And there are new medications that are out, but we're not as worried about the side effects from some of the older ones. A lot of those sort of cause dry mouth and constipation and other things. We're trying to move away from those, and I think the insurance companies are slowly coming on board for some of the newer medications which don't have those side effects. And then we call them sort of third line therapy when we talk about it, but understandably, I don't think third line means very much to patients. We think about first line as being behavioral changes, second line being medicine, and then third line being those therapies that come after medications. And those in particular, we have nerve modulation treatments where we actually can stimulate nerves in the ankle or in with the tailbone to help with bladder function. And then there's also Botox, which a lot of people think of for injecting, for cosmetic purposes, but it actually works quite well for overactivity in the bladder. So that would be the mainstay of treatment if symptoms develop.
I have a question, Jack. So before, in the past, you had to bring your own Botox. Has that changed? No, it's true.
Yeah. So there's really, it's a good question. simple answer, I think, for Medicare, frankly, and then a complicated answer for just about every other insurance. The way Botox works is there's a procedure, and we sort of say, hey, we've decided to do this procedure, and then the question is, the procedure gets approved by sort of insurance as procedures do, and then the Botox has to come from somewhere. With Medicare, it's actually very straightforward. So taking a patient who has Medicare, putting it on the schedule, we actually are able to buy it and then just bill Medicare for the Botox afterwards. And it winds up being fairly inexpensive. And that's sort of in the OR setting or in the office setting. With other insurances, we do what's called a specialty pharmacy. And I'm not sure if that has come up for other things. It doesn't come up in my practice all that often for other issues, maybe in your practice.
We use it a lot.
And so what we will do is, send in a prescription. It will go to a specialty pharmacy, and that pharmacy will run it through your insurance like any prescription. And they call the patient and say, hey, this is your copay for this particular medication, and is it okay, since it's yours, if we send it to the doctor instead of sending it directly to you? And you say, okay, and then it gets sent to us, and then we're able to manage it.
So it's BYOB, basically.
Exactly, yeah, in those circumstances.
So Josh, you like the oncologist, you take people's bladders out as well. Maybe speak to that. When does it all fail and you actually have to take a bladder out? Tell us about those situations.
Sure. Obviously, I think the difference is, although we're moving a little bit in a different direction. We're trying to preserve the bladder more and more and avoid having to do cystectomy. It is a tough operation, but it's certainly one that helps people when they get it. I think the difference for me is that when patients come in and they have cancer, understandably they say, I just want it out of me, and they want it removed, even if they wish it didn't have to necessarily involve, a surgery with a lot of risk and a challenging recovery at times. For me, I'm doing everything possible not to have to remove the bladder, but there are some bladders that they're impacting somebody's everyday life in such a profound and dramatic way that there just is no way to preserve it. And the way that they may be the case would be recurrent urinary infections. The bladder can sort of actually functionally shrink in size so much, an increase in pressure that urine actually backs up to the kidney. There's continuous urine leakage. There may be fistulas that may arise where the bladder communicates with other surrounding organs. And in those circumstances, preserving the bladder is not doing any favors to anybody. And typically when patients get to that point, one of the few times where you can operate on someone and the day after surgery, they feel so much better than they did the day before. So when that happens.
Any more questions out there? I know we have a little bit more time. Perfect.
Okay. I think it's been addressed already, but my question is the transplant. Of the bladder.
The bladder. So
bladder and
really complicated. Yeah, because there's all the blood vessels to the bladder. Bladder is one of the hardest organs to remove. It really wasn't meant to come out. There's the plexus of blood vessels that anchor the bladder are very dense. They're very adherent to kind of the pelvic floor, the rectum, the vagina in women. It's just, this is an organ that is not like, for instance, a gallbladder where, is just kind of, very separate from the rest of the body. This is very integrated into the body. So, and one of the reasons why, because it needs such a strong blood supply. It really needs a lot of blood flow. So when you remove a bladder from an organ donor, there's just all these blood vessels that you have to connect. So that's one of the challenges to solve is, when you transplant a kidney, there's 1 or 2 arteries in each kidney, and you just have to sew that. Here, you really have to figure out how to sew, kind of get all those. And what I believe what they're doing, Josh, is they're taking kind of the big vessels, the iliac vessels, together that's kind of the innovation here, is you take kind of the big vessels that feed all the little vessels, and you take that out from the donor together, and then you sew that in. But the big challenge is, I saw the trial, and there's a little bit of sort of big discussion in the oncology world is why are we choosing cancer patients as the trial? Because you're gonna, when you do a transplant, it's coming, somebody else's organs are coming in, and they're going to, if you just leave them, they're going to get rejected by your immune system. So you have to, there's a whole science out there now with, you can transplant hearts, you can transplant kidneys, you can transplant pancreases. And so there's obviously all that knowledge of how to immunosuppress a person the right way in order for this organ not to get rejected. But when you immunosuppress somebody, that also you lower the surveillance or the kind of the body's ability to fight cancer. So if this was a cancer patient and you're immunosuppressing them, that's a challenge. Is this appropriate? And that's the big question out there. And first of all, is it going to work? But if it does work, is it the right thing for a cancer patient to be immunosuppressed really forever?
The other thing is, as it comes to that, why I'm so skeptical of bladder transplant in some way, is that the bladder, we think of it as maybe it's this just organ that doesn't do a whole lot of thinking. It just kind of fills up, and when you want it to empty, it empties. But it's very complicated. It relies on a perfect communication between essentially all different parts of the nervous system. The part that voluntarily moves muscle, and then the part for the fight or flight part of the nervous system, and the rest and digest part of the nervous system. All these different parts have to act in coordination. And I see it all the time in my practice where patients have a neurologic injury, and one of those sort of parts of the nervous system is disrupted, and bladder function becomes significantly disrupted, and a major impact on their quality of life. So stroke would be a good example, spinal cord injury, multiple sclerosis. And for a bladder transplant to be able to pick up that complex neural network and pathways and work the way the patient would want it to, I don't know that it's going to wind up working, but maybe someday. I just can't imagine that we're not far off from that.
My second question is concerning BCG.
Okay.
I'm a pharmacist. I'm a retired pharmacist. 9 years ago, when I had my first surgery, not here, elsewhere, they operated on me, and then they told me that I needed BCG. It was not available. Sanofi and Merck were the two companies that made it. Sanofi had a fire in Europe. Lines were down. And some other reasons I don't know. But anyway, Merck continued. Merck was making it. And I investigated, and I was seeing a lot of these new medications that were like $50,000 and $100,000. When I looked at BCG, and vial of BCG at that time, 9 years ago, as I recall, was under $200 a vial. Okay? Now, the fact is, maybe the manufacturer with that product can't find the profit that they're looking for to sustain the manufacture of that product, and didn't have the ability, because of the insurance companies, to elevate the price to a fair price that they could afford to manufacture. So is anybody doing anything to get after these insurance companies to force them to increase the price they pay to these drug manufacturers? So maybe if it was $200 a vial, so maybe it would be $250 a vial. That's not a grandstand amount of money. So
Right.
They would maybe think more about producing them.
It's a spicy question. I'm going to answer it this way. So there is definitely an issue with BCG production, and Merck has been the only, for the Merck representatives here, shout out to them. They've stayed true to it. It's not, as you say, they don't make a profit off this. And what BCG is Bacillus calmette-guerin. I mean, it is a bacteria. It's a tuberculous bacteria that is attenuated, that doesn't generally infect humans. And you put it in the bladder, and it basically generates an immune response. It's sort of this, we talk about immunotherapy. It is the, OG of immunotherapy, okay? And it's very difficult to manufacture. And the shortages come when there's a contamination in one of the steps of the process. And my understanding is that it's a sort of multi-step process where they literally grow this bacteria. And if it gets contaminated at some point, kind of that batch is gone. And I don't know the exact number, but apparently it's sort of weeks to months to make a batch. So that's where the shortages come in. The last CEO of Merck, my understanding upon his retirement, actually committed to having another facility built to make BCG to help mitigate the shortages. So apparently that's being done. But I'll tell you what the big effort is now. We just opened this trial here. It's called the Bridge trial. There's a very promising combination of chemotherapy agents. Just to say it, different chemotherapy agents have been tested against BCG for 45 years now. I mean, since BCG was sort of described, and nothing is measured up. BCG has been the best. And so there is now a contender, which is a combination of gemcitabine and docetaxel, this gemdosi, which looks like it's quite good. And it's honestly better than the immunotherapy agents for non-muscle invasive disease. This combination is quite effective for BCG unresponsive patients. For patients who have failed BCG, we give it like water here. We have so many patients that fail BCG, come here, and we try to spare their bladders and give them gemdosi. And now we just opened a trial that basically allows us, when we're going to try to enroll everybody who comes to us because of the shortages, a very important question. If we give gemdosi up front as a first-line therapy, is that as good as BCG, right? And that's something we're testing now, and that would be a game changer. Gemdosi is cheap and easy. And if it's, I'd say cheap and easy, the one caveat, it's 2 medicines, so you have to stay in the office longer because you have to give one after the other, but that's trivial compared to some of these unattainable shortages where you just can't get the get the medicine. Yeah. I know there's a question here. Yep, good. Perfect. Yeah.
Yeah, good question. So it depends on the situation somewhat. There is not one marker that we, unfortunately, that helps us decide that immunotherapy is absolutely going to be effective. We do look at a few different markers that can increase the chances that it's going to work. If we're going to go into the weeds a little bit, these immunotherapy drugs that we're talking about target this pathway called PD-1. And we can look at something called PD-L1 and how much of it the cancer actually expresses or puts on the outside of the cancer cell, and we can test for that. And cancers that have a higher expression of that, in bladder cancer it's 10% or more, they have an increased chance of benefiting from immunotherapy. But this is basically, it goes from about a 20% chance to maybe a 35% chance. And so it's far from the ideal biomarker that we're looking for. There are some other markers that we look at, for example, something called tumor mutation burden. This is really just the idea that the more mutations your cancer has seems to make it more immunogenic. The immune system is more likely for it to work against. And it's probably just sort of a test marker. The more mutations you have, maybe the more likely you have that key mutation that is going to be the one that your immune system is going to respond to or recognize once we put these immunotherapy drugs in place. So these patients that have a higher tumor mutation burden, and this is actually true not just in bladder cancers but across all cancers, that also increases your chance of responding. So we do look at those and send those on most patients to sometimes help. But for most patients, we don't necessarily have those markers, and there are patients that can benefit from immunotherapy, and this is true from other cancers too. And I know that's something relevant to you, that they can benefit from these drugs even when they don't have these markers. And so, and I'll just end on, and I'll always sort of go back to clinical trials. But one of the things that we're continuing to look at is how do we find better markers and improve our ability to figure out the patients most likely to benefit, or maybe the ones that aren't going to, or develop resistance, and how do we sort of route them to better therapies that are more likely to help them.
We have a question here.
Hi. So I just wanted to circle back to what the other women had asked earlier about the commercial. So I had also seen that commercial, and it had said that when the gentleman was diagnosed with bladder cancer that he chose Fox Chase, and that Fox Chase was able to build him a new bladder. So I was thinking that was a reality, but it's sounding like from what you have been saying thus far that it's really not.
Oh no, I must have sort of no. It is a reality. So we no. I mean, we can make a new bladder. It's called the neo bladder, and there's other diversions like an Indiana pouch where you really use the gastrointestinal tract and you form it into a reservoir, into something that can store urine, and that it works just like a bladder. So my patients with new bladders, I mean, there's definitely some quirks, and not everybody's new bladder is perfect, and there's some risk with it. But there are patients that have perfect new bladders that, really urinate out of their urethra and, don't have a stoma, and that's the idea. But, there's some additional risks to those diversions versus the usual diversions, which are ileal conduit. So, I mean, I actually haven't seen the commercial. I don't know what exactly they say, but
Gotta watch TV more.
yeah, I know. I mean that's a reality that that's something that we offer here, regularly.
Just as the non-urologist, and just add, so I mean, I think the key difference here, right, is transplanting a full bladder from somebody else, right, to a person who needs it for cancer or whatever, for whatever reason, versus creating a sort of pseudo bladder or a neo bladder, some sort of other vessel to collect urine from their own normal tissues. And so I think that's a differentiation. Neo bladders are a reality that our urology team is doing all the time. Transplanting the bladder is a fantasy at the moment.
Yep. Yeah, there we go.
So if you've been in the program for 3 years, like I have, PCB and here, are there protocols for having newer samples as opposed to waiting that would be effective in detecting these?
So like a Cologuard type, instead of getting colonoscopy, getting the. So there are companies that offer that. It's actually, one of the companies was developed in New Zealand. Because in the companies from New Zealand, because it was developed, there's just not enough urologists to do the scopes. But all those tests measure up to a cystoscopy, and they're pretty good, but they're not as good as a cystoscopy. So, I mean, there are patients that really hate the cystoscopies, and sometimes we say, well, we can use this as an alternative. Most people, don't love them, but it's tolerable. And I mean, the gold standard is a cystoscopy. If that answers the question. Yeah.
And I'll just add, we have a researcher here who has a prime interest in being able to study urine and using urine as a way to detect biomarkers, whether that's to detect an early bladder cancer or detect recurrence, or be able to tell whose bladder has maybe responded to treatment. And so, that's that's an area of research that we're very invested in and has been part of a lot of the different trials that I mentioned before.
Josh, you want to? I mean, I'll tell you, regular kidney stones, no, but there are situations where, for instance, somebody has a chronic stone that's undiagnosed and it's sitting in the kidney or sitting in the bladder that can cause chronic inflammation and irritation, and you can have a cancer. It's actually a really rare scenario. Josh, any thoughts?
Yeah, when stones are responsible for recurrent infections and inflammation, that would be a circumstance in which that may arise, but not typically.
That's a no. I mean, yeah, that's a no. Yeah, if somebody has kidney stones, you don't have to worry that they're going to develop a cancer. That's not a major risk factor.
Hi, when I saw about reconstructive urology, my question is about a revision surgery following a traditional cystoprostatectomy with a urostomy, and there is stricture in the ureter, so the flow is not right, and so they have a diversionary catheter in the urostomy. Okay, so that's not working well. My husband is currently in the hospital with his 4th bout of sepsis because of that, because every time they change it every 6 weeks, he gets septic. So how successful is revision surgery? Who does the revision surgery? Is everybody exceptional at that, or is there somebody that we could see who really is successful at revision surgery?
So I'll tell you that. So this is lots of expertise here, and there's folks. This institution does more cystectomies, almost double cystectomies than other institutions in the regions and really in the state. So we classically, the oncologists, folks who took out the bladders, that's a complication that occurs. Actually, interestingly, just as a quick aside, we've started using SPY, which is sort of this technology that's used by plastic surgeons to identify blood flow to tissue, and we started using that to identify at the time of cystectomy blood flow to the ureters, and we've markedly cut down our rates of these kind of problems. But they're still not zero. Nothing. You're sewing basically a general urinary organ, which is the ureter, to a gastrointestinal organ, and sometimes that blood flow doesn't sort of dovetail perfectly, and you get a stricture. And so, to answer your question, the oncologists used to be doing all this work for our own patients when that happened, but we have one of the superstars of reconstructive urology, which is Dr. Simhan, who is here, and I tell you, the stuff he takes on is unbelievable. Redo. 10 people have tried and failed, and he'll fix it. So Simhan is the person to see.
Thank you.
Okay.
Yeah, I mean the rate of stricture is on the left side at least. When we've studied, it's probably about 10%. I wish we were lower.
What
Maybe we're
percent,
getting.
sir?
It's about 10% for the left ureter. So it's pretty common, unfortunately. But I would say that the nice thing is that once it's strictured and you have a nephrostomy tube in, typically when you just have the nephrostomy tube and not the stent that goes all the way down, you can define exactly where the ureter's healthy and where it isn't. And so people are beat up by the process of having a stricture. They don't feel good. They can get infections, and they may not make them the best sort of candidate to go through another big surgery. But when you know exactly where that ureter's healthy, it's sort of like, we talk about SPY, it's like super SPY. You know exactly where the ureter is okay. And in that case, you have a very high success rate, generally speaking, on your patients.
Yeah, I didn't know, what percent of revision is successful because, they say there's no guarantees second time around either. So I didn't know if there was
I've done quite a few of these surgeries over the years. I mean, this is one of these things. The minute you say it, it happens. I mean, to Josh's point, where you really, if you do it right and you mobilize everything and you can see where, it really works. It's very rare for it to restricture if
Do they often have to take another piece of the bowel to create a new urostomy? Because
no.
we heard that you may have to have that done again as well.
It depends on the details of the case. Usually very unlikely. Usually you can make the plumbing reach, and it usually is okay.
Thank you so much.
No problem.
When will the drug belzutifan be available? And does a kidney cancer patient have to have that genetic?
Really good question.
I can take this. That's okay.
That's a great question.
We don't know exactly when it's going to be available. Oh, so the question is, when is a drug called belzutifan, a drug I had sort of hinted at, which is a newer agent that targets a new pathway that's important in kidney cancer. This was the pathway that I mentioned. Someone won the Nobel Prize for studying and discovering. And this drug that targets it, the first drug that targets it, is a drug called belzutifan, and a drug that we had in early clinical trials here. And it's basically the sort of the trial that will get it approved, the phase 3 trial that will demonstrate its effectiveness, we're still waiting for the final results of, and so that needs to be presented and then submitted to the FDA, and so we're probably still at least a year away, most likely. The drug is approved for a specific subset of kidney cancer patients who have inherited a specific mutation in the von Hippel-Lindau gene, and those patients can get that drug, not just for their kidney cancer, but the other manifestations of that disease, which actually it's quite effective in controlling. And as a result, because the drug is out there, for some patients, we can sometimes appeal to the insurance company to get the drug approved for patients who have been on other therapies, but approval is probably still a little ways away. Probably at least a year. Thanks, Ken. So most bladder cancers are not hereditary in nature. Most of them are probably related to some sort of exposure, tobacco being the most common, but there are other environmental and occupational exposures that can increase the risk of bladder cancers. There are some conditions that can be associated with some urothelial carcinomas. I would say more commonly the upper tract urothelial carcinoma, so the ureter tumors are associated with something called Lynch syndrome. And so those are instances where we will send patients for genetic testing, and that can have implications for other family members. This is less common in bladder cancer, but it's not zero, but it's relatively small.
Yeah, a lot of these cancers, at least the way we understand them, it's not just one gene. It's sort of different genes have to unite in one person, and so the next generation kind of gets scrambled sets. So it's not they're not as much risk. And then, like Matt said, in bladder cancer especially, really in kidney cancer too, it's a lot of environmental exposure. Is that right? Yeah. Well, there's so much we don't understand. That there's our genetics program is very, very strong, and some of the things that they do is that they once patients see them, if there are new discoveries and new mutations that that come up in a certain field, and patients sort of had seen them, they reach back out to them and they update them and say, well, we saw you 5 years ago, we didn't think there was a risk, but actually there's a new risk factor that's been discovered. And that, things change in that space every year. There's just so much discovery. No more questions. I think we can wrap it up, and thank you all for coming. Obviously, we really appreciate it. This program has been recorded, and it will be on the Fox Chase YouTube channel. So if you found it useful and you wanted somebody else to listen to it, it's there. And I'm being told to save the date for July 1st, which is Survivor Celebration. Details will be emailed to everybody who the institution has an address to. Thank you for coming. Have a great night.
Thanks for everybody coming out tonight and joining us here. We appreciate all of the interest, and this can be pretty casual. All of us are open to being interrupted, and if there are questions as we talk about our various topics. I'm David Chen. I'm one of the urologic oncologists here, and I see a lot of faces that I recognize, and again, thank you to the patients that I have the privilege of taking care of for your coming out. And on this side of the table, I have some excellent partners that are also going to be able to share some experiences and some topics that we've come up with to just discuss in brief. But I think our goal here is to give you, as people in the audience and our patients, the opportunity to ask questions as well. And so we can keep the schedule a little bit open to change based on what seems to be of interest. There are a number of specialists here that I represent our surgical team, and Dr. Simhan represents our new division and group of benign reconstructive urology. So we've always been focused on the cancer side of urology and have really been unable to address some of the other issues as well that are important but are not directly cancer related. And Dr. Simhan and some of the new partners of our group are really world-renowned experts in a lot of these other complementary parts. Dr. Wong, to my left, is one of our excellent radiation oncologists, and to her left is Dr. Miran, who is one of our new medical oncology specialists and is really a future scientist and translational expert, and can talk a lot about some of the new exciting work that's going on. So this room is supposed to talk about prostate cancer, and there's a lot to talk about, both in terms of treatments as well as quality of life and aspects to try to maintain the other part of the picture of treatment, which is some of the side effects that happen, I think some of the I'm just going to spend like 5 minutes talking about things in general. Of the common question that I get is what's different, what's new, what's changed, and I think more and more we're recognizing that prostate cancer is not one problem that treats that needs the same treatment or is going to afflict a man the same way, and every case really has the opportunity to be individualized, and the approach you take needs to take into account a lot of what the person who has it, what's their priority, and what their objectives are about the cancer. There were a couple interesting studies that have come out over the last year, and I think they highlight a lot of what we've already known for a long time. But one thing I'll highlight on some of the research is there was a major study that got published just a month ago from the UK. It was in the New England Journal of Medicine, which is probably the premier medical publication. It was a report of what's called the PROTECT study, and it was looking at men who were signed up in the UK, so they have a socialized medical system and they have a little bit more ability to sort of tell people what to do. And in men with an early level of prostate cancer, they invited them to come in and offered them 3 different directions. That some people got treatment right away, and some men had surgery right away. Some men ended up having radiation treatment right away, and a third group was offered the opportunity to be on surveillance. And I know many people in this audience may have been on surveillance for a bit or are on surveillance. And I think the interesting point of the study is after 15 years of follow-up, roughly 3% of men died from prostate cancer. So, depending on your viewpoint, 3%, it's not 0, but it's certainly not 50%, it's not 20%. So men, whether they had surgery or radiation or even were on follow-up and surveillance, only about 3% of men died at the end of 15 years. So I think that emphasizes for a lot of men, prostate cancer is not this immediate rush to do something, and having something done right away doesn't always make a big change. I think there's been some newspaper articles about this, and it's a little bit misleading because they sort of gloss over the fact that in the men who didn't have anything done, they were on surveillance, most of them ended up getting treatment. So it wasn't that they were on surveillance and 15 years later, none of them had anything done and things were the same. 3 and 4 men ended up getting treatment over the course of 15 years. So the majority of men who start off on surveillance did end up getting something done. But it seems to suggest that if you don't get treated right away and you get treated later on, you do okay. That the delay in having treatment by surgery or radiation doesn't mean you're worse off because you didn't rush to have it taken care of right away. There were greater number of men who may not have died from prostate cancer but had advanced prostate cancer. They had metastatic disease if they didn't get treated right away. So the urologists, the radiation oncologists who are sort of more active in suggesting you get treatment, they look at the study and say, well, it's helpful to treat you because the chance of this getting worse is less. That getting metastatic disease is also probably not an ideal result. But I think overall it's encouraging for us to think about other options and to move away from the need to treat people right away and rush to have something done. And that's where we are looking very closely at having a little bit of an intermediate step that maybe some people need treatment, but maybe we don't need to do radical therapy and surgery and removal, or maybe we don't need to do radiation therapy. And there's a big push to try to pursue what's called focal therapy or limited treatment. That if in some cases, as we get better with technology and imaging and can find the cancer, we're able to successfully treat less of the prostate. Maybe we don't have to go through the full deal and treat the entirety of the prostate if the cancer is in a limited location. And so that's an area of really heavy research, and I'm involved in that with one of my partners, Dr. Andres Correa, and it's something that I think makes Fox Chase unique. Is we're not necessarily looking at only the standards, but also trying to investigate the opportunities to do things a little bit differently and offer some intermediate steps if that's an option. And with that, I think I'll probably stop and turn things over to Dr. Mirren.
Thank you. So, pleasure to be here and to see all your faces today. So I think I want to kind of piggyback on what Dr. Chen started talking about, and his first point about how the treatment for prostate cancer for men can really be individualized. And one of the ways that I think we've made some strides is by incorporating new technologies. And so I wanted to highlight one of them that we all kind of use in our practice in different ways. But it takes advantage of a marker that's present on prostate cancer cells. It's called PSMA. It's called prostate-specific membrane antigen, is a scientific name for it. Essentially, it's something that lives on the surface of prostate cancer cells, and it's pretty unique to that type of cell. So there's been technology that's invented to try to use scanners that we've had before with a new tracer agent to try to highlight where the prostate cancer cells are in the body. And so that's called a PSMA PET scan. It's similar to other types of PET scans, but uses this new novel approach to specifically target prostate cancer. And I think to the point that Dr. Chen made, it's really allowed us to kind of individualize and be more specific about how we take care of men with prostate cancer. I think we're trying to learn how to use it best in a lot of different situations. I think one of the common ones is trying to learn more specifically if a PSA is rising, for example. I think many of you know what a PSA means, but the laboratory test that we use to monitor prostate cancer. If a PSA is rising in a patient that with the older type of scans we used, we couldn't see anything. Sometimes now we can identify locations of prostate cancer more sensitively. Another way that we use it is that because it's this marker is present pretty specifically on prostate cancer cells, it can help us understand if a finding on a scan actually is prostate cancer more likely than not, sometimes without needing a biopsy. And so we've been trying to integrate this in different ways, and so we think that we're trying to help individualize treatment, try to not over-treat, but be more specific about how we take care of our patients, and so I think that's been a great advance. The other thing that I wanted to highlight is that there's also therapeutics that have been developed that target this specific marker that I mentioned, called PSMA, and one of those particular drugs, if you want to call it, is a targeted radiation treatment. The brand name of it's called Pluvicto or lutetium PSMA, and so they've kind of linked the technology that we learned about with imaging to a treatment, and it's currently available in the U.S. for men who've already been treated with multiple lines in the advanced disease setting. They're testing it in all different other types of situations, but it's been shown in that more advanced disease setting where men have had already hormone therapy and chemotherapy to prolong life, and also delay the progression of prostate cancer on scans. So, it's another new option that we have, and we do offer it here. We also have a clinical trial using a different variation of that technology that's being used a little bit earlier in the care of prostate cancer. So we're trying to be active in having options for our patients, obviously the approved options, but also clinical trials, and I think that's just one of the ones that we have. We have multiple options for prostate cancer, obviously other types of cancers as well. So I think those are the main things that I wanted to highlight, and look forward to questions.
Go ahead, I think you have a question. That's fine.
So the PSMA, suppose you have cells that escape and might be other parts of your body. How sensitive is that to be able to, if you're new agents, to be able to check out who those cells are? Do you need a lump of them, or a lot of them, something down some, or are they just be able to
That's a good question. I think, I don't have a precise answer, but to speak in kind of orders of magnitude or general terms, I think it's on the order of thousands for sure, and maybe even more, unfortunately, still. But I think one way to look at it in a different way is with PSA. So typically, if someone had a PSA that was pretty low, like, around 1, 2, maybe even below 1, the chance of finding something on a scan would be pretty low. And the PSA, not for all men, but often reflects the amount of prostate cancer that's there. And so I guess the one way I could kind of quantify the advantage is that, with low PSAs, we've been able to find things that we didn't used to in that situation. And it's not really a cell number thing, but it's a general identification of how much there is. It definitely is more sensitive. Sorry, I'll repeat the next. Okay.
So follow-up to that is, instead of quantifying a number of cells, you mentioned low PSA. So if you're measuring on the ultra-sensitive PSA scale, you'd really be off the scale low for PSMA to work. Is that right?
Yeah, I think, in most situations when the PSA is kind of too low for the conventional PSA test, this probably would be a low chance of finding something. And, the ultra-sensitive tests, really, that means there's a very low amount if you're below the threshold of the conventional PSA. So I don't think it would be, it's not particularly useful in that situation, but still useful in kind of that lower range of conventional PSA. Thank you.
So if the PSA test is really low, ultra-sensitive, eventually it's going to be more. And at the point it becomes more, a PSA test doesn't tell you where in your body it is, but your agent is going at the area. Right?
Yeah, so I'll repeat the question because you didn't have the microphone. I should have done that in the beginning. But yeah, so the question was, or kind of statement question, was that, as if the PSA should rise with an ultrasensitive test and it gets to a level where it could be detected with a conventional test, you still don't know where that's originating from. And that's been a frustration kind of for a long time. And so that's one of the things I was alluding to earlier, is it does help you in those situations when you get to a certain threshold in identifying sometimes where the area is. Sometimes that means it's amenable to like a local treatment to potentially delay the need for a systemic treatment or a treatment that goes in your whole body. So that's one of the ways that we try to use it to individualize when it's appropriate. Obviously, there's caveats to when that applies, but that's a good question. Thank you.
I was wondering if you could comment on the lack of information regarding the probability of a false negative with the PSMA PET scan and how it hampers the patient's choice to choose between surgery and radiation.
So just want to make sure I understand the question. So the question was about the chance of a false negative and how it would impact your choice for surgery or radiation. So with any test, there's a chance of a false negative. A false negative, for those who may not know, means that the test says it's negative, and that means in a scan that there's nothing on the scan, but in reality there is something there that we don't see. So that's a false negative, meaning that it's not really negative, but we said it was negative. How that impacts your decision about surgery or radiation, I think that's it's complicated, it's individualized. I think it depends what the situation is and what the information you had surrounding the test. You can't just use the test to decide and the false negative rate to really make a decision about that. I think the same principles kind of apply that we used before about surgery, radiation, that my colleagues know a lot more about than I do, but we try to work together to come up with the best suggestion for each person, and ultimately it's a little bit individual. So I don't think the test explicitly drives that decision making more than before. Of a false negative? Not off the top of my head, I'm sorry. But it depends on the level. With any false negative rate, it depends on the chance of it being true to begin with. So if you're using it in a setting where the chance of it being positive is really, really, really low, like in a PSA that's too low, then the false negative rate goes up. If you're using it in a setting where the chance of it being positive is higher, the false negative rate changes. So there's not one false negative rate. It just depends on the context. So it's hard to answer that question.
Okay, I have two questions actually. I was under surveillance for a year and a half, and then I had hormone therapy and 40 treatments of radiation. My last PSA was very low. What's the chance of this going back up again now that I've had all this happen? Question number one. Question number two, can you talk to me about the fact that I have had severe impact of bladder and bowel activity since my radiation treatment? I have diarrhea frequently, and I go to the bathroom maybe 10 times a day, maybe more.
I guess this ends up being directed a little bit more at me, which is okay. I think, we certainly do our best to minimize side effects with everything that we're doing. The ultimate goal is to be able to treat the prostate cancer, but certainly we don't want to neglect any other effects that might come from the treatments that we give. It's hard to say kind of off the top of my head the exact, recurrence rates. If that is also something that is very individualized for each person's case, and how aggressive or the different stages of cancer and things like that. And it's another thing that's very personalized to each patient. But certainly with definitive treatment, we do our best to have the best cure rates that we possibly can with as little side effects as we possibly can. And certainly we're not perfect with everything, but we're certainly working as best we can to improve all of those sorts of things. That leads into what I was going to talk about, or what you were going to talk about. But
Yeah, that might lead some into me. My name is Jay Simhan. It's great to see everyone here today. I would say it's really my honor to be a member of the team here at Fox Chase, largely because with Drs. Wong, Mirren, as well as Dr. Chen, you're really hearing from leading experts in cancer therapy. And of course, to summarize cancer therapy in 30 minutes for an organ is impossible. So everyone here is trying their best to perhaps give you just snippets, perhaps, of how these problems can be dealt with. Oncologists really study cancer, report on cancer, and treat patients with cancer. And they help give plans that are individualized to you. The funniest thing is I'm also very happy that I'm here because I too am learning various treatments and the nuances of various treatments, because I'm not per se the cancer urologist. I'm actually a side effect urologist. So a lot of the treatments that I provide for patients are patients that might undergo cancer therapy for urology organs like prostate, bladder, kidney, etc. And they then face a treatment side effect, whether it's surgery, whether it's radiation, or it's systemic therapy. And some systemic therapies might be managed certainly by the medical oncology team. But then if there are sort of side effects, I would say the most common ones with prostate cancer therapy are leakage, urinary leakage, or erectile dysfunction, or some of the bowel concerns that the gentleman in the back raised. And so we have now, I think, a team at Fox Chase where there are several of us that really have an interest in the quality of life recovery following cancer therapy. So what I think Dr. Chen was saying earlier about a very recent study revealing that really a very small percentage of people died after prostate cancer. When you look over many years, I would say to you that's great. And I would also say to you that here at the Cancer Center, there are a proportion of patients that have side effects also. They're certainly not dying, but they're not happy with how they're living. And that's ultimately where I sort of, come in. And so I'll spend just a few minutes talking about what that means. And if that certainly raises any questions, I'm happy to do my very best to speak to that. But ultimately, erectile dysfunction, I would say the two or three most common things would be really erectile dysfunction following prostate cancer therapy. And that's not really a target on surgical therapy or radiation therapy or really systemic therapy. That's really just a cancer-based problem, you know, and a treatment-based problem for a cancer that really might affect a lot of people in this room. So erectile dysfunction, really difficulty achieving an erection following therapy is something that can be treated with various mechanisms. I think a lot of patients might hear about really pills and pill-based management for that. There's also injectional treatments, there's external devices, there's surgical-based therapy for erections that can be done. And the surgical-based therapy, when people hear, you know, surgical-based, they might be concerned over that. It's actually considered a minor surgical procedure, and people generally, like 30 to 45 minute type surgical procedure, people go home the same day type of thing. Again, that's a very brief snippet, and happy to talk in greater detail about what that actually means. But that's sort of one umbrella of new care that's now offered at the Cancer Center that I think is important for people to know. A second sort of umbrella of things that come up with prostate cancer-based treatment is urinary issues, voiding issues, incontinence. Certain people have incontinence, certain people have hesitancy or urgency to go. Again, a team-based approach here is to try to individualize what that might mean for any one patient. One of my partners, who's was the one that we cracked the joke about earlier, stuck in the operating room, Josh Cohn and I, take care of a lot of patients that have voiding-based issues after prostate cancer therapy. Some of those issues require bladder-based treatments that are pills, again, or more invasive treatments that can be done in the office that might involve injections, and then other therapies that might require, again, minor surgical procedures that are under 1 hour type procedures that are now done routinely here at Fox Chase, and again, patients go home in the same day. A third type of issue that comes up with either surgical therapy or radiation therapy are urinary blockages, where the outlet of the bladder just simply doesn't empty effectively because what I would call it's a plumbing problem. It is a plumbing problem. And certain plumbing issues can require, again, very straightforward surgical-based therapies that at least I would say for us are more straightforward because we see them commonly in a small percentage of people. But because Fox Chase, I think, has the reason why I'm here is because I think it has a good reputation and I think it has a good team of people taking care of patients. We're fortunate to see that small percentage of people and offer them the best possible tailored therapy that we can. But in short, I would say those are really the three domains of problems that are the most common domains of problems. Following prostate cancer-based therapy, erectile dysfunction, voiding or urinary leakage issues, and urinary blockage issues. And all of those can get managed effectively. And for the gentleman in the back that also raised an issue about bowel-based issues, those are also things that can get managed by one of the partners in the team here. So thank you. Happy to answer questions about that, certainly. And I'll also pass this on to Dr. Wong. Thank you very much.
Well, I think that leads really nicely into what I was going to talk about as well. If anyone has been down to the radiation oncology department in the past probably year and a half, probably the very first thing you'll see is a giant sign that says, "Please pardon our appearance as we're working to improve our patient care by upgrading all of our machines." So we have been going through a slow and steady renovation to upgrade the entire group of radiation treatment machines that affect how every single patient gets treated, no matter what kind of stage you're in, what different treatment options are available for you. Most likely, the machine that we were working on for you has recently been upgraded in the past year or two. So there's been a huge investment by the health system, by Fox Chase, and by the department to be able to bring you the most state-of-the-art care that we possibly can for all patients. So be it brachytherapy, more conventional sorts of treatments, stereotactic body radiation therapy, any of the different kinds of things that we might talk about for you. you're getting the newest, greatest things that are out there. This allows us to improve not just the standard treatments that we give, but lets us be able to innovate in how we are giving our radiation treatments, to be able to expand the indications that we're using radiation for, to be able to increase the effective dose that we're able to give you while decreasing side effects to normal tissues around. To highlight one of the particular machines that we have, we now can offer adaptive radiation therapy, which is a cone beam CT-based adaptive treatment. We are one of the first in the country to be able to offer this sort of treatment. A lot of times on clinical trial, we have the very first adaptive cone beam CT-based stereotactic body radiation therapy for the prostate adaptive treatment in the country. Got the very first patient in the country on this trial 2 to 3 weeks ago, to be able to offer more treatments for people. Adaptive radiation therapy changes the plan minute to minute, exactly how to adapt to the needs of the patient on the table at that time. So traditionally, radiation is planned ahead of time. You come in for a planning. We make sure that everything is very accurate for what we're doing, and then we set you up each time. We verify that everything looks good, and if it doesn't, we gotta change how you're setting up. You know, we can change how much your bladder is full, or maybe the exact positioning that you're in, but we can't change the plan itself. And this one allows us to do treatment planning on the fly with the patient on the table, to make sure that we are being as accurate and safe and precise as we can possibly be. Using this newer technology with this cone beam CT-based adaptive therapy lets us do this in a much quicker way than has been able to do some other places, may use other equipment, sometimes MRI-based, and these treatments end up being an hour long, an hour and a half long each time. And with being able to use this newer technology, we can do it in a time frame that's not that much longer than a regular radiation treatment might be, maybe something on the order of about 30 minutes. Right now, it's mostly in the stereotactic body radiation therapy, SBRT setting, which is sort of 5 or fewer treatments. We have clinical trials coming out, some that are already open, both for intact prostate, so upfront treatment just for localized disease. We have some more that are coming down the pipeline for oligometastatic disease, so prostate cancer that might have spread, or other cancers as well, that might have spread to other parts of your body, as well as definitive treatment for bladder cancer. So there's a lot of really promising things, a lot of newer things out there that can hopefully allow for dose escalation for better control rates with less side effects for the future. Happy to answer as many questions as you might have.
Yeah, just with the equipment that you just mentioned, I didn't hear proton. Do you have proton?
We do not. So proton ends up being kind of like a philosophical divide. You have to kind of make that distinction before you get started. Proton treatment is very, very similar to regular radiation treatments with X-rays or photons. It's just the particle that carries the radiation itself. It requires a lot of infrastructure to be able to use, so you kind of have to, institutions have to decide if they're going one direction versus another direction. And there are certain circumstances where it is very, very helpful. The benefits of protons is that they can come in from a direction and stop. And that's very helpful when you have, an infant with a teeny tiny brain tumor in the back of their brain. You can come in just one direction, one beam, and then not get what's in front of it. The problem with prostate cancer is that the prostate is a sphere within a sphere of your pelvis, and there's not one direction that you can come in and spare everything else. So that beam has to get broken up anyways into a number of smaller beams, and then the benefits of having a particle to be able to transmit that end up kind of going away because you're coming in from multiple directions like you would with an X-ray anyways, and it doesn't quite have the longevity that photon radiation has, so there haven't been able to be a lot of the technological advances that we have in how we deliver photon-based radiation therapy. Those just aren't there, so the techniques used to give proton therapy is kind of like what we would have done 10 years ago or more, because it's just not quite as compatible, that it takes a little bit longer to develop those things for something, for that type of technology. So certainly there are benefits to proton therapy. I think everything that's come out so far, there are still some clinical trials out there that we're waiting for final results on. I actually ran a study in partnership with Penn and a couple of other study centers around the country, just looking at how people go through these sorts of things. And from everything that we see so far, they are very equivalent, but neither one was significantly better than the other.
I wanted to go back to the issue of side effects. And although it's great that Dr. Simhan is here to help with that, I wonder what the team is doing to inform patients better about potential side effects. Because with knowledge, maybe you keep your worries down. And I know it's quite miserable, the situation the man described. I'm just wondering, what are you doing to include like patient education in terms of side effects?
Certainly. I think patient education is extremely important. We try to take our time at initial consult and all of the preparatory phases before getting started with radiation to try to give as accurate a picture as we possibly can. It's very hard to individualize. Some people are a little bit more sensitive and some people are a little less, and it's hard to predict exactly what will happen to each patient, but kind of giving the range of side effects. I think an important part of education is also education from each other. I think the patient-to-patient network is very important of helping patients know what it is like, because we can explain as best we can, but we're not actually the people that are going through the treatment. So talking to somebody else who's been through this and what their experience has been is also extremely helpful. And then doing everything we can on our end to minimize side effects as much as possible. With radiation, a lot of of side effects can be limited by not radiating certain areas. So being able to find new techniques to be more conformal, to have less radiation exposure to other parts of the body is one of the main ways that we can try to minimize this as much as we possibly can for the future.
Dr. Bond, when you have the prostate cancer moved to the clavicle, and you've already had radiation in the clavicle once, would the proton therapy be recommended over doing radiation again in the clavicle?
Specifically to the clavicle, I'm not quite sure. Sometimes there are certain circumstances where it can be useful to come in just one direction. So I always, if anyone is ever considering some other kind of treatment, I'm all for education and having you consult with someone who does that sort of treatment. If it's better, it's better, and we want the best treatment for you, if it's with us or if it's not. So I'm all about education and getting all the opinions that you need. If it's the better treatment, it's the better treatment.
What's the difference between the cone-based and CyberKnife?
So this is like the next generation version of the CyberKnife treatment. CyberKnife is a brand name of one specific machine. We have one of those. It is up at our satellite in Buckingham. That is programmed to do a specific type of radiation treatment called stereotactic body radiation therapy, which is kind of like the generic term as opposed to the brand name. And that's just a way of giving the radiation with higher doses in less treatments. That's in a more focused area to kind of minimize radiation exposure to other parts of the body. The CyberKnife machine itself only does that sort of treatment. It doesn't do any other treatments, so can be a little bit more limited. And so oftentimes we use that generic term, so we can use whatever machine, even newer machines and different machines that can function as kind of Swiss Army knives and do a lot of different treatments, including that sort of a treatment. This newer version of it uses all of those same techniques that you would use on a CyberKnife machine or anything else that would do that stereotactic radiation, but can also do the planning portion that often happens in the background in the few days before you get started with radiation, also at the time that you're getting your treatment, in a way that doesn't keep you on the table for forever, but still lets us be able to adapt and change the entire treatment plan for you to what you need right at that minute for your treatment.
I was just wondering if someone could give us an update on the sort of state of the art of gene therapy right now. For one example, like if you had a loss of exons in the ATM DNA repair gene, and you could use a PARP inhibitor drug, but I'm just wondering, where the gene therapy research is now to actually going in and repairing the damaged ATM gene that's not repairing DNA problems.
So just to kind of repeat the question, and I'm happy to take it. So the question is essentially, in cancer, prostate cancer being one of them, a lot of times different genes that are normally functioning stop working as they're supposed to. And so the question is, where's the status of gene therapies that could replace or replenish the function of those important ones that get lost? ATM being a specific example, but there's a lot of different examples in prostate cancer and other types of cancer. And so I think to answer the question simply is that it's still, early days for those type of treatments for cancer. I think where we've seen gene therapies be more successful is in replacing genes for people who've lost them entirely, like children who are born with congenital issues, where they can't make any copies of a certain thing like ATM or something like that. There it's a little bit clearer how to use it because you're putting it in their whole body and every part of their body needs it. One of the issues with cancer is that it's only not working well in the cancer. The rest of your body may have a normal copy of ATM, and depending on the situation. So it's still in infancy. I hope that someday it becomes more well developed, but it's still very early days in cancer care.
I have a question for Dr. Chen. I was diagnosed in 2019, prostate cancer, and elected to have radiation, and was happy I came to Fox Chase, very successful, still here. And afterward, they schedule follow-ups, but I ran into COVID, and everything came to a standstill. So I did have a FaceTime with, I don't know, a fellow named Mike, I think. He might have been a PA. But after that, nothing. So I'm wondering, should I still have follow-up? Should I be seeing a urologist? I do have my PSA done annually, and the numbers are, always under 1, 0.1 or something like that. Should I still be seeing somebody?
So the question was, after radiation treatment, do you need to see a urologist? I think that's sort of a general question. And I think there's a common idea that urologists in some ways are sort of counterpoints to gynecologists, that women tend to see gynecologists for a long time, and after a while men see urologists for a while. At the same time, I think if you're doing fine, meaning the radiation has been effective and you're not having bladder issues, urinary changes, or symptoms, I think as urologists, we're happy to see you, but there may not be something that we necessarily have to address proactively. That a lot of times men are sent to a urologist because there's a problem that they get up at night urinating, or their PSA is high, or something. And if the main issue you saw a urologist in the beginning was because your PSA was high, you were finding to have cancer, and your cancer's been treated, I think seeing a urologist is helpful if you're not seeing somebody else who's on top of the cancer and following things, and generally after the radiation therapy, it's monitoring the PSA. We often continue seeing patients long after the radiation therapy happens, partly because there are some side effects, and sometimes there are some changes that we're looking to work on and help out with. But I also have had a lot of patients who, after a couple of years, sort of say, do I have to see you anymore because things are fine, and I'm getting my PSA checked with my primary doctor, and I think that's okay too. that primarily to follow the cancer, the PSA is an important number. And if you're feeling well and you're not having changes that are side effects necessarily from treatment, you don't necessarily have to have a wellness check, so to speak. So.
So it's a question for Dr. Wong. In salvage therapy, all right, so I've had prostate cancer surgery, prostate's removed, seminal glands removed, etc. And I understand as long as the PSA is below 0.2, I won't see you. But so suppose that you do get to that point. I guess my question is, the prostate's gone, a lot of the architecture's gone. What do you target, and how do you know? And so I was interested actually in hearing about the PET scanning, because okay, because I've used PET scans in my own work. But what do you typically do? I mean, how does that work?
That's a great question. There's a few different parts to that, in that even with, first, the PSMA PET scan is fantastic when it's helpful. Sometimes we'd be assuming it's in the area where you had your surgery, and suddenly we didn't realize there was also a lymph node or an area in the bone that might also have been involved, and we wouldn't have targeted that, and now we can find it because of the PET scan. But a lot of times in the situation that you're talking about, in a salvage situation, where we just start to see that PSA start to rise, we're still below where we can find things on the PSMA PET scan. And a lot of times we have to go off of sort of the collective knowledge of what's happened to men in the past. And various studies and other clinical practice has shown that the most common place for prostate cancer to come back, especially with certain high-risk features at the time of surgery, is right around the area where you had your surgery. We call that the prostate bed. And there's been a lot of work at being able to map out where those recurrences occur, things like that, to find what we consider as more sort of general landmarks of the areas that are at risk that we try to cover. It's also with working with surgeons and knowing kind of the approach that you take, what are the areas, what is typically kind of the boundaries of where they would do their surgery, to be able to target all of those areas to make sure that any of that higher risk region gets covered with the radiation.
So a question about radiation. When the radiation's finished, as he said, you pretty much destroyed, you destroyed the cancer. The idea is behind it. But you've also, because it's not totally precise, you've also done some damage to other tissues. What's the incidence of problems with cancer happening or other types of damage happening because of the radiation that's not prostate cancer?
So I think there's
In other words, another cancer being developed.
Certainly. Any type of therapy can put you at a higher risk for a secondary cancer down the line. Radiation is a little bit higher than sometimes other treatments because of that. Because radiation can damage DNA. A lot of times those normal tissues repair. Most of the time, pretty much all the time, the normal tissues repair and are fine afterwards. But there's always the situation that you can affect normal tissue function, or even change, predispose someone to potentially developing a secondary cancer down the line. That risk gets minimized with the less of a person that you radiate and the less radiation exposure to those normal tissues. So I do think that these numbers are changing quite a bit. But, the traditional incidence of a secondary cancer, which is considered a cancer not related to your prostate cancer, so something like a secondary bladder cancer or rectal cancer that happens after treatment, it falls on the range of about 1 in 100 to 1 in 1,000 in the 10 to 20 years following the radiation treatment.
Thank you for having this seminar. I appreciate that. My situation is somewhat similar to other gentlemen described. I came here, PSA was like 19 or something. Took the radiation, 5 treatments, and then next time I checked, PSA was 0.46, and then 0.56, and then 0.88. I never had any side effects or any kind of symptoms. What point should I be worried? checking PSA every 6 months, but it seems like it's creeping up very slowly.
Sure. So PSA kinetics following radiation treatments is a very interesting field of study, and I think there's a lot that's going into exactly how different men have their PSA change over time. Typically, with having, it sounds like you had stereotactic body radiation therapy with that 5 treatment course. Sounds like you still have a prostate there. And there can be variation that happens due to the normal prostate tissue, not necessarily because of the prostate cancer itself. So variations within something on the order of about 1 point or so of PSA are often considered completely normal. A lot of times the threshold that we say of something to be clinically significant with PSA is something on the order of about 2 nanograms per milliliter. So if you started out at 0.55, getting up to something like 2.55, but there can be a little bit of nuance within it. That's why we keep checking. We want to make sure that things stay relatively stable over time.
Yes, I think this question is for Dr. Wong. A few minutes ago, a gentleman asked a question about CyberKnife. And back in 2016, when I was diagnosed, I went to, I think it's Philadelphia CyberKnife, which is actually not in Philadelphia, it's in Haverford, I believe. It's in Havertown or Haverford. But it's more of a statement than a question that I have. And that is, I went there and the urologist told me that CyberKnife was really for people who have prostate cancer that present a certain profile, a certain PSA, a certain Gleason score. It's not just for anybody that has prostate cancer. So in other words, what I was told, my recollection is that if you have a PSA of maybe lower than 6.5, and if your Gleason score is not a very aggressive Gleason score, they could work with you.
Certainly.
With CyberKnife. So the point I'm making is some of these treatments, the modalities, they work best with certain people who present a certain profile as opposed to other people, because sometimes I also belong to patient-to-patient network. One of the things that I tell the people that are sent to me is that even though I have prostate cancer, we have prostate cancer, our prostate cancers may not be the same. So the treatment that I receive is not necessarily the treatment that you should receive, but I can tell you why I selected the treatment that I have. So my question really goes to this whole CyberKnife thing, because some people hear about it, the way it's advertised on the radio and the television is that, oh, this is the thing. And it may not be for you, and then again, it may be for you, depending on your profile, what factors you present.
I think I couldn't say that better myself. I completely agree. Everyone is a little bit different going through these sorts of things. I think we sort of started off this whole discussion talking about how to personalize treatment, that prostate cancer isn't a one-size-fits-all. Not all treatment options are the best for each person in here. And to find really what is the best for you as a patient. So certainly there are certain people who, treatments like stereotactic body radiation therapy or SBRT or CyberKnife isn't the right thing for them due to the stage of their cancer, other factors like the size of your prostate, and all sorts of other things that go into a treatment decision. And so that's why it's really important to have that initial consultation to discuss, this is what I think is right for you, instead of just looking at sort of generic information for any person.
Now, I have a question about active surveillance. I've been on active surveillance for 6 years now here at Fox Chase with Dr. Uzo. And one of the surveillance things is the MRI with contrast, which I'm going to have my 4th one next week. I've had 2 other MRIs with contrast for another reason in that same time frame, so we're talking 6 and 6 years. At what point is too much contrast bad for like your kidneys and your bladder and everything else? I mean, what's a safe number of MRIs with contrast that I should be having?
So that's an excellent question in terms of is there a danger to the scans and the MRI or specifically the contrast in what we're doing? And that's a question for many of the cancers that we take care of, not just prostate cancer, but a lot of the people with other cancers will get a CT scan periodically or frequently. I think we don't really know the answer in terms of how much is too much, but at least I think we can feel pretty confident that the contrast used for an MRI specifically doesn't have a lot of known harms. I mean, I would agree. I think as much as we can do it less often, that's helpful. I think that MRI does seem to give the best detail and provide the most information, and that's why we use it so often. But I think as we learn more about, again, even men on active surveillance probably have different levels that they need to have an MRI or need to have a biopsy, and for some men we can try to do it less often. But one of the areas that we are exploring, and you could bring this up with Dr. Uzo as well, there's an alternative test called the micro-ultrasound. So that also seems to be a useful non-MRI type of scan, but also gives a lot of detail to the prostate. So I think as we learn more about these new developments and new technologies, trying to find the right balance on how often to use them is an important goal.
By the way, the first thing I would say, I read Philadelphia Magazine. I don't know the other doctors there because Dr. Shen and I are buddies. He was voted one of the top doctors.
Thank you, Dr. Ayal.
You owe me a meal. You owe me a lunch now, the Beckford, all right? By the way, I did send him an article on the value just recently of the digital examination versus the PSA in one of the magazines, medical magazines, and they really encouraged the PSA when they felt with the PSA you have more chances of picking it out rather than the digital, which was less error. I just want to say a few things that happened to me. These are things that you read. Number one, when I was in general practice, you read that, well, take tomatoes, take lycopene, and that'll help chances of getting cancer of the prostate. Well, since I was 50, I was eating tomatoes like there was no tomorrow, especially in the summer with the Jersey tomatoes, right? And also, I was taking lycopene, high doses, for years, and I still ended up with cancer of the prostate, so I'm not, it's questionable whether it really helped. The other one that no one talks about, I want you to know about. Jefferson's been working on the value of vitamin C, IV, for certain, like cancer of the lung, cancer of the prostate. I don't know what results I have, but I've been getting chelation from my heart, which I like very much. I'm 93 years old, so that speaks for the chelation. I thank God every day also, you can imagine. But the other thing I was taking, Dr. Shen, when my PSA went up to 40, of course we saw you, and but what happened was then I said, well, I was getting chelation, how about giving me high doses of vitamin C with another thing, I think it's called K3, and they gave me, so every week I was getting high doses of vitamin C, because there are a few books written where they say, take vitamin C IV, and that'll attack the prostate. Well, maybe I'm the exception, because it didn't do anything to me. It didn't affect my prostate. If anything, my PSA is going up. So people, if you hear about, in fact, there's a fellow at Penn, initial visit is $2,500, and he treats you with vitamin C. So know about these things because they're going to come up. So look, I'm not saying they're not effective. It wasn't effective on me, although you read some books and some people it's helped. And I don't want to talk about proton, because I love proton. So, and you don't do protons, I don't want to go there. I'm getting a CT scan tomorrow, and then right now my PSA has been going up, even though I'm on drugs that hinder the testosterone. As you know, I'm taking the T-candy and the injections. But I know there'll be other things that you can give, because you mentioned that, and I appreciate that. I hope I don't have to go to radiation, because that's not going to be one of my favorite things. Well, I'm in your hands, so I'm not, I always tell Dr. Shen, I was a doctor for 40 years. I'll tell him to take care, I can handle his back without a deal, but I'll do that, and he's going to tell me how to take care of my prostate. And I bless you. Thank you very much. God bless.
How do you follow that up? So my question is pretty simple. Some of your partners out there at booths were talking about tumor testing. Can you speak to tumor testing? What is it and when do you do it?
That's a good question.
Why do you do it?
Very good question. So the question is tumor testing, why do you do it and when do you do it? So I think as technology advances, the subtypes of what does the tumor test mean, obviously there are different options of what is out there. I think as a medical oncologist, so someone who treats advanced cancer, we're integrating them more and more. And when I say tumor test, I mean really a test to look at not just what it looks like under a microscope, but what it looks like as on a molecular level. So looking at the DNA changes, the RNA changes. For those of you who don't know what that means, it's essentially the genetic material that makes up the tumor and what has changed kind of from what you would expect normally. So I'd say that for a lot of men with prostate cancer now, we're using it more and more in the advanced setting. So patients or men who've had the disease spread to other areas and now are seeing usually a medical oncologist. That's usually when it comes up where it has like a practical use as of today. That might change, and there may be reason to use it earlier as technology changes and our knowledge changes. But in general terms, I would say for men with prostate cancer, a time to maybe bring it up with your medical oncologist is, if you've had the experience of having your prostate cancer spread and you're getting therapy for that, it might be a good thing to consider.
Dr. Miron and Dr. Wong, you both spoke about newer therapies or newer things coming up on the forefront. Have either of you ever heard of cryotherapy or hyperbaric chamber therapy? Anybody hear anything about that in relations to, I guess, maybe stopping it, preventing it, using any, or along those lines? I know it's out there, but there are therapies and there's talk about it, so I'd just like to know your point of view.
So I can comment at least on the cryotherapy, and this may or may not be what you've heard about or learned about. I think there historically has been surgery as a treatment where you remove the prostate, and we've developed very good alternative to surgery with radiation therapy, where you can leave everything in place, and the radiation will cause damage to the prostate and the cells, and the cancer can die off. And then there's been different equipment, and these are surgical devices that can be applied into the prostate, either to treat the entire prostate or you could treat certain areas. And so a cryoablation machine, a cryosurgical device, is one way that you can treat the prostate. And it's not a device made for the prostate, but it's just a surgical tool, so you can apply it to the kidney, to the liver. And so that is one way that the prostate can be treated as an alternative to surgery or as an alternative to radiation therapy. We do use that here. It's generally a procedure that's done in the operating room, and it's done with anesthesia. And for people who are familiar with brachytherapy and how that works with radiation therapy, it's in a similar setup that while a patient is under anesthesia, instead of applying the seeds, as they're sort of referred to, it's applying a device that is based on putting a needle into the area of the prostate that you want to treat, or you can treat the entire prostate that way. It's just one alternative means to treat the prostate. There are certainly advantages and disadvantages of that kind of treatment. And it's one of many other types of treatment that are being used and developed to hopefully be more pinpoint over time. That another device that has gotten a little bit of publicity recently is there's a nanoknife machine or an irreversible electroporation machine. It's an electrical device. And so it's also another way to treat different parts of the body, treat the pancreas, treat the liver, or in our use here, we're using it to treat the prostate. So the question is, what were the symptoms or maybe the changes or the side effects? It is a treatment that physically destroys an area, and so I think in a simplistic description, it's like having a burn on your hand. It'll blister, it'll swell, it'll react. And so an area that we treat, if we treat the prostate, it commonly swells up quite a bit. And so there are some side effects that are expected from the treatment. So for example, that's a kind of treatment that we might suggest is an option in a man who's had radiation therapy and there still is some cancer and we're thinking about how to treat the prostate again. It can be difficult to remove the prostate at that point. To do a prostatectomy if you've had radiation first is possible, but can be challenging. And treating the prostate with cryosurgery, cryoablation, can be an effective way to treat the prostate and not go through the steps of removal, but it does lead to swelling and inflammation. And so commonly for a period of time, a man, if he has that kind of treatment, we're going to expect they're going to have difficulty urinating, they're going to have a hard time emptying their bladder, and finishing that treatment, we would start off with a catheter and use that for a period of time. That's one example of some of this change.
So a question, as I'm sitting here thinking to myself, I had the radiation about 2 years ago, and I read a lot about it. One of the things I read was that after the radiation, there's side effects, and those side effects go on, maybe erectile dysfunction 2 to 3 years later, and this, another 5 years later, and all these different data and studies. What do we know now that'll let me sleep at night? When's it going to stop evolving?
I would say for the most part, side effects that come from radiation are pretty rare to just completely pop up out of nowhere many years down the line. A lot of times it's more likely that an issue that you might have had earlier might persist a little bit longer or may change a little bit. But for the most part, if you're doing well, I think there's a pretty small chance that something catastrophic or something that would very much affect you might pop up out of the blue. This is our last question.
Thank you. So I had my prostate removed. I had follow-up hormone therapy and radiation therapy, but the cancer cells are very persistent, so it's come back. And so now I'm on long-term hormone therapy. I'm taking calcium every day, have been for years, but I'm just wondering, what are the risks of long-term hormone therapy? And are there things that I can do in addition to taking calcium that might limit the risk?
Sure. So the question is, what are the long-term risks of hormone therapy, which some people have to get if their cancer kind of persists after multiple treatments? So I think, testosterone is kind of a central hormone for men. It has a lot of effects on the body. Obviously, we reduce it kind of globally, so a lot of those things can occur that testosterone is important for. I think specifically things that you can work on are physical exercise, and you mentioned calcium and vitamin D. That's really because hormone therapy can increase your risk of your bones weakening over time. Some people can develop what's called osteoporosis, which is like a medical term for that. Essentially, so in order to prevent it, you replenish the calcium and vitamin D. There are other treatments for that if it should occur, but by strengthening the muscles around the bones, you can really prevent that from becoming an issue that would actually affect you. So that's one thing. Physical exercise, obviously a great thing for many different parts of the body. And the other risk factor that we do see with hormone therapy is, heart issues or heart disease that can be increased with hormone therapy. That's a long-term side effect. So if you're getting hormone therapy for a short amount of time, it's probably not going to be an issue for you. But if you have to be on it long-term, it's something that we kind of know about, but we have to deal with because we think the benefit of getting the treatment outweighs that risk. So, physical exercise is good for that as well. And obviously, doing all the regular things that you should be doing as a person who's, you know, in a certain age group or at risk for other types of medical problems, you should still do. I think those are two things I think that we try to address pretty proactively, and so physical exercise and then supplementation that we recommend, like you mentioned, and those are the two of the main things that, you know, you can kind of take in your hands a bit.
Is there a specific exercise regimen that is recommended, or just more weight training or aerobic?
Yeah, it's a good question. So there are a lot of great resources out there. One place that we usually point people to is like foundations that have kind of material specifically generated that are kind of easy to understand and put things into practical perspective. So for prostate cancer, the Prostate Cancer Foundation has resources online. I think in general terms, what we usually suggest to people is kind of low weight. Obviously, this is all within what you feel like you can do comfortably and not put yourself at risk, but kind of low weight bearing exercises is a good thing to do because it builds up the muscle, or at least maintains it, to try to maintain some strength. And also aerobic exercise is good as well.
All right, I want to thank everyone. That's all the time we have this evening. I want to appreciate really everyone for coming, but also thank my colleagues here for dedicating their time to be at the event. We appreciate you spending your night with us. The program actually has been recorded and will be uploaded to the Fox Chase YouTube page next month. So if there's something that you might have missed, then you'll be able to sort of watch a video recording of this and hear some of the questions and answers that were given. Please check our website for upcoming patient programs and events. Save the date for July 1st for our annual Survivor Celebration. Details will be emailed to all patients. Thanks again. Good night and take care.